Welcome, everyone, to the December 21st, 2020 COVID-19 clinical care rounds focused on EMS patient care and operations. I'm John Kramer. I'm an emergency and EMS physician. I'm the director of the Office of EMS, the National Highway Traffic Safety Administration, and the team lead for the HHS Healthcare Resiliency Working Group EMS pre-hospital team. I'm also the EMS medical director for the Caroline County, Maryland Department of Emergency Services. The purpose of these sessions is peer-to-peer real-time sharing of COVID-19 EMS challenges and successes. In developing these sessions, our guiding principle is, if I'm preparing my EMS system for COVID-19 patients, the clinicians I want to hear from are those who have the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated in this series. It's not intended to be redundant or replace any organization's initiatives. It is intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Special thanks to Project ECHO, Dr. Bruce Strumminger, Amanda Dazan, Amy Armistead, Celine and Max, and the rest of their team for the peer-to-peer learning platform we're using for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are typically US noon Eastern time. Tuesday typically are critical care rounds. Wednesday is a special series on outpatient therapeutic modalities. And Thursday is typically emergency department rounds. We should note that there will be no clinical rounds this Thursday or at all next week. It's self-evident from our nation's medical response challenges that they're changing every day. And we continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For the ECHO clinical rounds, we continue to have participants from many states and multiple countries, the participants being predominantly physicians, nurses, and EMS clinicians. An additional appreciation to NETEC, the National Emerging Special Pathogens Training and Education Center, for their support for these rounds. These ECHO clinical rounds and NETEC's webinars are complementary to each other. We continue to receive many questions for each of these rounds and apologize in advance that we're not able to answer all of them. We have selected major themes from questions received and hope to cover many of those over the course of these sessions. We'll also be doing crowdsourcing and polling questions with the results shown in real time, so that we have the opportunity to learn together. I'd now like to turn it over to Amanda Dazan to review some of the logistics and other information. Amanda.
Thank you, and hello everyone. My name is Amanda Dazan with Project ECHO. Just a couple quick things to go over before we get started today. Down at the bottom of your screen, you'll see a Q&A function in Zoom. That for any questions or comments you have regarding the presentations or topics. Please use the chat for anything regarding technical or logistic issues. Today's session is being recorded and your attendance is consent to be recorded, so thank you. The presentations that will be shared today were linked to the most recent announcement that went out this morning from us at Project ECHO, and will also be linked to our website, which we'll put that link in the chat for you in a minute, along with the recording once that's ready to go. In the last 15 minutes, we will also be putting a link in the chat to claim your CME or continuing professional development credits via the University of New Mexico. That link is also available in that announcement that we sent out this morning. And Just a quick reminder to everybody that these sessions are focused on improving patient care and health systems and supporting clinicians. So we appreciate everybody keeping it apolitical and non-commercial. Just a quick note on data use. We do collect data through a variety of different ways for these sessions, and we wanted to make sure everybody knows that everything is kept completely confidential. What we do share is de-identified, and you can see our full data use statement here, also available down at the bottom of that same announcement that we mentioned. A quick reminder, as mentioned, NETEC does have complimentary webinars to our sessions. You can find them on their website. We'll put that link in the chat for you in just a minute. And they also have recordings of past sessions on topics that may also be of interest. So we recommend checking that out. On Wednesdays, we have the COVID-19 Outpatient Therapeutics mini-series. It'll be the same time as these sessions, just on Wednesdays, starting up again on January 6th. So we'll put a link in the chat where you can register for those if interested. One more quick reminder that the AAMC has a continually updated COVID-19 clinical guidance repository, and we recommend taking a look at that. And finally, the crowdsourcing question. So back to you.
Great, thank you, Amanda. We have used this crowdsourcing question in the past, and again, we're looking to get some temporal information from you all. So, as we have talked about on multiple sessions in the past, concerns with increasing complacency among EMS clinicians. With that aspect in mind, please address the, yeah, right. Come on, John. With that aspect, with what aspect of the response are we finding that our EMS clinicians are becoming most complacent? And what can we all do collectively to address that issue? As you're responding, as we've done in the past, please indicate a country that you're responding from if outside the United States. And if within the US, please indicate the area or state from which you are responding. Thank you. We have talked repeatedly on these sessions about the issue of stress to the EMS system and stress to the emergency department. Over time, healthcare systems and emergency departments have become stressed to the point that they have required the ability to go on diversion or have had delayed times in the ability of ambulances to offload their patients once they've arrived in the emergency department. This is the topic that we're going to address today, and I'm really honored to have our two speakers. Jim Augustine is an emergency physician in the Mercy Bon Secours Health Systems and is a clinical professor in the Department of Emergency Medicine at Wright State University in Dayton. He currently serves as the medical director for several fire-based EMS systems in Atlanta, Dayton, and Naples, Florida. Jim completed his undergraduate training at the at the Ohio State University. I always flinch when I say that because I'm a grad of the University of Michigan Medical School. But we'll give it to you, Jim. You went to the Ohio State University. He did his medical school training and emergency medicine residency at Wright State University in Dayton. And Jim and I actually were residency mates during our residency. Dr. Carl Schultz is Professor Emeritus of Emergency Medicine and Public Health at the UC Irvine School of Medicine and former director of the EMS and Disaster Medical Services Fellowship at UC Irvine Medical Center. He's currently the medical director for Orange County, California. He graduated from UC Irvine School of Medicine and is residency trained and board certified in both emergency medicine and internal medicine. Jim and Carl, thank you for joining us today. Jim, I'll turn it over to you first. Thanks.
Thank you, John. Pleasure to be here. And my computer's malfunctioning in terms of sharing slides, so we're going to do these centrally. We are in a very challenging time, and this is typically a challenging time anyway in many of the jurisdictions where I operate because we get into our winter respiratory illness volumes and the emergency departments get very busy, especially on a day like today, which is Monday. And so EMS offload times and the problem with diversion have been a long time issue. And of course, this year we have additional challenges. So EMS offload time issues will be the subject of some suggestions today and some ideas to take back to your planning groups across your region. Next slide. I have a puppy behind me who insists every time that I don't pay attention to her that she make noise, so forgive me. All right, so EDs are in a challenging time. Acuity exceptionally higher than in the non-COVID times. Our inpatient units are closed or very tight on beds. And when admitted patients are not able to move to the inpatient units, we refer to that as patient boarding. So patient boarding in the emergency medicine and EMS literature refers to inpatients that are there in the emergency department for a prolonged period of time. And as they occupy both beds and staff, those beds and staff are unable to accommodate incoming patients. Those incoming patients may arrive ambulatory or arrive on an ambulance stretcher. And of course, the sicker the patients are in the emergency department, the more they occupy both. COVID patients define sicker patients. And then with additional needs for PPE use and negative pressure rooms, the ED is left in a position where they cannot absorb incoming patients. Recall that the two usual input points to the hospital are labor and delivery and the emergency department. We're going to kind of focus on the ED today because labor and delivery in general absorbs incoming ambulances without significant issues. Frankly, the emergency department should learn from the way labor and delivery is able to accommodate incoming patients. But for this session, we're going to focus on the ED. And this session does not specifically refer to freestanding emergency departments, which may be part of hospital systems, and at this point may be open and accepting EMS patients, particularly if the mothership is full. Next slide, please. During the transition of care from EMS providers to the hospital, and the hospital would mean emergency department staff, is again an ongoing challenge. Always ahead of his time, Ray Fowler, a year ago, April 2019, wrote an article in GEMS that talked about transition of care, including a length of time, and is defined by a length of time, for care to be turned over from EMS of the patient, using the necessary equipment, and very importantly, communicating to the emergency department staff the clinical conditions of the patient, what needed to be done and what had been done already, and that the emergency department staff were actively managing the patient at that time. So those are the elements of excellent transition of care from EMS to the hospital. Thank you, Dr. Fowler. Next slide. The critical issue now is that, and why this is different than it was in the spring, is across the United States, most hospitals are desperately attempting to keep their elective schedules open. So continue to do orthopedic, cardiac, cancer, GI, and other care, and keep schedules in place even as there's a surge of COVID patients that are challenging bed needs within the institution. So we have at this point not closed down the elective care systems, and hospitals are carefully trying to balance the needs of the COVID patients versus the non-COVID patients, and in particular try to keep the surgery schedule in place. We could at this point quote EMTALA to the hospitals and talk about the necessity to absorb patients. We probably are not at that place in most of the United States now. Next slide, please. I want to make sure everybody knows the data on the use of the emergency department. In general, there are big numbers of patients who go to emergency departments in the United States each year. That's about 160 million visits per year to emergency departments. So that's a use of the ED, about 450 uses of the ED per 1,000 people per year in the United States. About 17% of ED patients arrive on an ambulance stretcher. 17%. That means 83% walk in. It means utilization of EMS is about 100 uses per 1,000 population per year, with about 20 of those uses not resulting in an ED visit. So we have about a 20% non-transport rate in EMS in the United States. That has been increasing, as all of you know, as we have patients that are frankly scared to go into the emergency department or hospital. We process patients in the emergency department, whether they walk in or arrive by EMS. And in the end, across this country, about 81% of patients who arrive in the ED are treated and released. About 17% are admitted. About 2% are transferred, and about 2% leave before treatment is complete. The admission rate is about 40% for ambulance patients. It is about 11% for walk-in patients. So the data would say EMS patients arrive and generally are much sicker, have much more need for inpatient services, and likely are spending a longer time in the emergency department. So that's our baseline. And this year, both EMS and walk-in patients are sicker than they have been in prior years. Our volumes in the EDs are down a little, as they are in most EMS, and our admission rates are a little bit higher because of that. Next slide. I also want you to realize that in terms of getting to an inpatient bed in the institution, in the hospital, about 70% of people who arrive in an inpatient bed arrive in an ambulance, 70%. There are 3 other doors to the inpatient units. Those are labor and delivery, direct admission, and transfer in. And transfer in is much more common in our tertiary and quaternary level hospitals, who transfer in patients on helicopters and in MICUs to go directly to their operating rooms, ICUs, or cath labs. In the general population and for general hospitals, about 70% of patients in inpatient beds arrived through the emergency department. And again, a very high percentage of those arrive in an ambulance. What this says to you is that the EMS system in a community is very important to the health of the community and to the health of the hospital. And very honestly, the front door to the piggy bank at the hospital is brought in by the EMS units. Next slide. So what are we going to do when we begin to have lengthy times for processing patients out of the ambulances into the emergency departments? That is our current crisis. And again, for the factors up above and into the winter season, we are seeing very tight times for the emergency department and friction between EMS and the hospitals. In order to reduce that, we have a couple of kind of low-hanging fruit opportunities. Number one is to reduce the transports to the hospitals. And a reminder that in 2 weeks, the ET3 program from CMS starts, and that will pay EMS services for treatment in place outside of the hospital. And in some cases, it will pay for transport to alternate care facilities, dialysis units, clinics, sobering centers, and others. Potential number two is EMS in the back of the rig has 2 lawn chairs used for the EMS crew to wait on the wall with the patient until the patient has been received by the emergency department staff. Number 3 is a rotation of the hospitals sited somewhere outside of the hospitals so that you have someone who's sitting in the 911 center or in an executive office for the EMS system who is rotating the hospitals that are receiving patients. And with that typically is a mandatory transition time. A frequent time interval will be 30 minutes so that if there are units with patients waiting at the hospital for 30 minutes or more, the EMS system will place that hospital on diversion or bypass, and we'll call the charge nurse in the emergency department and say, hey, our medic 10 has been at your hospital for 30 minutes. We need them back on the streets. And we're asking that you immediately transition that patient's care into the emergency department so our unit can do what it's supposed to do. Another low-hanging fruit used in many communities is frequent EMS supervisor visits to the emergency department with a reminder to the ED staff, which is typically the techs, nurses, and physicians, that the EMS units are needed back on the streets and the patients need to be transitioned. A desperate measure is when the system decides that it needs to station specific crews in the emergency departments to receive all of the patients coming in on their units. And that separate crew manages the patients that are coming in and have not yet transitioned to emergency department care. This is not ideal transition. So you have the street crew turning over the care to the emergency department-based EMTs. Those EMTs receive a report, maybe do additional vital signs and management of the patient, continuing their care until the emergency department staff takes the care of the patient away from the EMS system altogether. But those EMTs stationed at the hospital can release the street crews and vehicles back into service. There are also the use of other spaces within the emergency department that are called vertical spaces. And there a patient is transitioned to a wheelchair or a chair. The EMS crew can get its stretcher, crew, and vehicle back in service. And those patients can be cared for in vertical spaces, some in the triage area, some to the waiting room, and some to other patient care rooms where eventually transition occurs in the care to the ED staff. So these are kind of immediate steps that can be taken and very frankly are being taken right now in the United States to care for patients. Next slide, please. In these COVID times, we also have a couple of other additional issues. Can you click to the first bullet? Number one, the tent areas and other alternate care sites outside the main ED that are monitored by the ED staff can be used as an offload area. And that offload area allows, again, transition of the patient to a lower acuity monitoring area until a bed in the main emergency department is opened. Next bullet is an alternate care site. And that would be some of the convention centers and other alternate care facilities that are being opened in many cities to manage patients. And in some cases, lower acuity EMS patients can be moved to those facilities as opposed to the emergency department. This works well if those facilities are staffed by other care providers and we're not stealing from the EMS system to staff those areas and continue to try to staff the medic units that are operating on the streets. So a couple of alternate areas provided to us in these current COVID times as we try to manage surges that would allow us to have another offload site for the EMS staff. Next slide, please. All of these require strategic planning, and really many of you are at the point now where a strategic regional group, including hospital CEOs, sit either virtually or socially distanced in an appropriate meeting site and discuss the current stress to the EMS system, the stress to the emergency department system, decide on what will provide the best patient care and what will let community resources be doing what they're supposed to do. EMS being in the streets providing care, emergency department being the processing of incoming patients, and the inpatient units absorbing inpatients in a timely way from the emergency department. Many times this requires a structured hospital work plan so that the chief nursing officer and the operating people from the hospital have to work on better plans of reducing patient boarding so that the ED beds can be opened for incoming EMS patients. In some cases, a good follow-up process can be developed where you leverage the competitive spirit amongst hospitals and hospital system by publicly sharing times amongst the systems and hospitals and doing individual CQI for unusually long turnover times. This will help us avoid what Carl's going to talk to us next about, which is in his county, what the county had to do, which was after a strategic meeting, come to an agreement that no one could go on diversion, that it was too stressful to the system, and left the EMS units to attempt to manage the needs in the community as well as long waiting times of their units at the hospital. There are many places that have moved to a no diversion strategy, and that's really important. I was in Washington, D.C. With John Kramer actually in 2009 when we worked the plan out for no diversion. It required the cooperation and leadership of the hospital CEOs to develop that plan. It was done in the middle of the H1N1 pandemic and required, again, structured hospital work plans that allowed inpatients to be taken out of the ED to produce the bed space that was needed for incoming EMS patients and those that walked in. So I will move forward and say in the phasing of this, next slide, it is still our responsibility to run the unscheduled care system. And EMS and the emergency department are the prime players in the unscheduled care system in the community. We have been carefully balancing the needs for community-based care with hospital-based care for the last 50 years. But during this time of unusual stress, we have found it very difficult to push through the walls of the hospital in a timely manner. So immediate strategic planning is needed. Much of that assists the hospital in being able to produce the flow that we do every day in the pre-hospital care system. And frankly, what our challenge is into the future. With that, I will turn it over to Carl, and I will take calls later in our session, correct, John? And we'll go from there. Thank you all very much.
Thanks very much, Jim. And while we're putting Carl's slides up, I guess I'll ask one probably politically related question, but Jim, you're involved with a number of EMS systems and communities that have multiple healthcare systems as well. Do you have one pearl that you've found applicable to all of those settings and healthcare systems that allows folks to be more agreeable to working together?
Well, the competitive nature of those systems that you mentioned is one place to start. And that is, you say, hey, with system one, we have found that their use of such and such as an offload area for the inpatient unit to be very successful. System two, is it possible that you could develop a specific, a similar way of doing that same kind of operation? So turning the competitive spirits together. I will commend in my communities where I have worked, the children's hospitals on a regular basis are much more adept at doing this than the adult hospitals. Each year during their RSV times, they turn on many units of their hospital. They find a way to staff them up to accommodate the RSV volumes during the year. So turning the competitive spirit to, can the children's hospitals do this and the adult hospitals can't? Sometimes is useful, John, and for our audience.
Thanks, Jim. Carl, please pull your slides up, and as Jim mentioned in one of his previous slides, you've implemented or worked with multiple healthcare systems to try and get some of these issues addressed. Please have at it. Share with us your experience. You're on mute, Carl.
How's that? Better?
That's much better. Thank you.
All right. So I want to thank you, Dr. Cronin, for inviting me to be on this program. What I will share takes about 10 minutes. It's not a long presentation, but the situation that we have been confronted with here in Orange County, California. Our system has about 3.1 million people, and we provide service through multiple different 911 providers and utilize 25 different emergency receiving centers, hospitals with emergency departments. And normally it works pretty well. Let me see if I can, I don't know why the slide isn't advancing. Let's see, let's try this. There we go. Okay. So we have a system that utilizes diversion, and it's been very successful for us through just about everything else. RSV, typical flu seasons, what have you. Our diversion system has really helped to share the load when unusual circumstances occur and specific hospitals are overwhelmed. They can go on diversion, and this means that there is no ambulance transport to their hospital. And this occurs in 2-hour increments. So we have something called the ReadyNet. I'm sure many other people use that. It's a way of linking all the hospitals by microwave communication, and each hospital can see what everybody else is doing. It works really well. And so they go on the ReadyNet and they go on diversion for 2 hours, and then the ReadyNet takes them off diversion automatically at 2 hours. So if they're still needing to be on diversion, they have to physically go back and put it back on. So this avoids problems with people going on diversion and then forgetting to take themselves off. And like I say, it has worked very well for us. And in the unusual situation where there's 3 hospitals in one region that are all on diversion at the same time, then the system takes them off diversion. So if 3 people are on diversion, then nobody's on diversion. And so that system has been in place for many years. We've had no real issues with it. Over time, we've tried to implement some metrics that look and give us a more specific measurement of how well the system is or isn't working. And one of those is our ambulance patient offload times, or APOT. And we had lots of debates about what would be the standard for this particular metric. And we eventually settled on the 90th percentile APOT time, which means that that's the amount of time it takes for an individual hospital to offload their ambulance patients 90% of the time over a 24-hour period. So an example being, let's say your hospital gets 10 ambulance runs in a 24-hour period. The 90% APOT time would be the maximum time it took to unload 9 of those 10 ambulances. And we set that standard at 30 minutes. So that the expectation from the EMS system is that you should be able to offload 90% of your ambulance runs in a 24-hour period within 30 minutes. And then this happened. So we were minding our own business, and then COVID. So what I'm showing you here is a timeline. This blue line is what I really want to pay attention to. That is the number of patients hospitalized in the 25 emergency receiving centers in Orange County. And this is sort of June, July, August as we go through. And this was our first peak in July, which we thought was really bad. We were really kind of nervous, and we did a lot of crazy things, and we got through it. And then it leveled off, and we sort of got complacent. We thought things were going pretty well. And then here you see what starts to happen around the beginning of November. And then, of course, it just went nuts. And we are now in a situation where the system is at the breaking point. There is just no more room at the inn. So what you're seeing in front of you is one of the other metrics besides the APOT time that we traditionally have measured, and that is the number of diversion hours within the county in a 24-hour period. So again, going back over to here, this is November 16th. This represents pretty much our typical pattern over many years. We'll see 20 to 25 total hours of diversion time in a 24-hour period. Sometimes, especially during the influenza season, it may perk up to maybe 50 or 60, and then it comes back down. So that has been our normal pattern. And what you start to see here is in December, we start to see a very atypical rise in the total number of diversion hours that occurred in the county in a 24-hour period. The max, just so give you a sort of a measurement ceiling, if every hospital in Orange County went on diversion for a whole 24-hour period, that would result in 600 hours of diversion time. It's 25 times 24. So as this number starts to rise, and here we have one that this is what drove our next decision, at 213 hours of diversion in a 24-hour period, that essentially was like taking a third of our hospitals completely offline for 24 hours. And we felt at that point that the situation was not sustainable. We were going to get into issues where ambulances simply would not be able to get patients to hospitals. Those hospitals that were still open would be then also going on diversion. And within a matter of a day or two, we would have the entire system on diversion for 24 hours. So we felt we had to take some sort of action, which we did. And I'll get to that in a minute. But what you're seeing here, why did it drop down to 0? Because this is the point where we said at 7 p.m. tonight, we are not going to tolerate diversion anymore. Diversion is gone. No one can go on diversion. That's why it goes down to 0. But right before that, at 7 p.m. when this took effect, we were already at 156 hours of diversion time. And the estimate would have been, again, probably in the 220 to 230 hours of diversion for that day. So we basically shut it down. And this is an example of a table that illustrates the number of hospitals and the hours that they're on diversion. So there's a listing here of all of our hospitals, and there's 20 of them here. And the next column is the only one that really matters. And this is the total number of hours in a 24-hour period that these hospitals are on diversion. And you can see this one here essentially was closed for an entire day. Here's another one that's almost closed for an entire day. And so it goes. So you can see once you get to around 200 hours or so, the system is at risk for everybody else going on diversion and the system locking up. And this is the sort of the last metric that we are currently now using to dictate our policy. This is the 90% APOT times. Traditionally, these have run around here, around 26 minutes. And this has been incredibly constant for 5 years. In spite of everything that's happened in Orange County, our APOT time at the 90th percentile has rarely, if ever, gotten above 30 minutes. Typically, at the end of the year, we do the average, and every year it's 26 to 28 minutes. So this has been a very solid metric, and we've done really well. We're very happy with it, and then it blew up. And as you can see, over time, the APOT, the 90% APOT starts to creep up, and right around here, now we're at 70 minutes. We've never been in that territory before. And that was the one that coincides with the 213 hours of diversion. And so that triggered our response to this crisis by suspending diversion. And that's where we are, as I sit here today, with diversion being suspended. And there are a couple of other things that we did now that we know that basically we're in crisis. The first thing we did is allow ambulances to travel greater distances. We had a constraint that said essentially you couldn't go outside your catchment area with rare exceptions like traumas or strokes that had to go to another receiving center. But generally, we had this sort of time when we wanted them within 20 minutes of their hospitals. We abandoned that and allowed them to drive much longer distances to find an open hospital. We established a rule that if an ambulance crew arrived at a hospital and could not offload their patient within 1 hour, they had EMS permission to basically leave that hospital and go to another facility. And yes, this probably is an EMTALA violation, although I'm not sure that EMTALA will be enforced. These patients have arrived at hospitals. They've not been seen by the hospital. They have not had a appropriate screening exam, and we have mandated that after an hour, it is appropriate to leave. And I don't know what the consequences of that is going to be, but it's simply not rational to leave patients at hospitals that are so overwhelmed that they can't even get the patient off the ambulance. And so we have implemented this as one possible solution. We have monitored now our APOT times very closely, our 90% APOT times, and established that we will suspend diversion until such time that we can get 90% APOT times down below 50 minutes. Because that's the point where the number of hospitals on diversion at any one time becomes manageable, and it is reasonable to reinstitute diversion. We have been in the 50 to 60 range until yesterday. Yesterday, we were at 47. I don't know what we're at today, but it will require 3 consecutive days of being below 50 minutes in order for me to reestablish diversion. We also explored the possibility of taking adults to the pediatric hospital, the children's hospital. I'll get to more to that in a minute. And that didn't work, but I'll go into that in the next couple of slides. We also considered, we haven't done this yet, but are considering an assess and refer policy, which means that if someone calls 911 and the paramedics go out and they feel that they're stable, they are authorized not to transport that patient. And that's never been done in Orange County. I know some places have done this. This is not new news, but for us, it would be a substantial departure from what we've normally done. But that is on the table, but not yet implemented. We have implemented an alternative care site, as Dr. Augustine talked about earlier. This was a hospital, it was a state hospital that was used for developmentally disadvantaged children, and it was in the process of being closed down. And we were able to convince the state to open it up for stable COVID patients, and it is currently basically a COVID receiving center from the rest of the hospitals where they have someone who is stable but unable to go home. They can be transferred to Fairview. The last thing we are doing as we speak is we're deploying mobile field hospitals to some of the larger hospitals in the area. They're establishing these secondary hospitals on hospital grounds. They'll probably go up this week and will expand capacity by 25 to 50 beds. Of course, we all know that beds don't take care of patients, people do. And staffing of these expanded facilities will be on the hospitals that requested them. And they are somehow magically, I'm not sure how they're doing it, but they're able to find enough staff that they can effectively staff these mobile field hospitals and expand their capacity. So what happened with the Children's Hospital? So a little background. Remember that slide I showed you earlier with the 2 blue peaks, one around July? At that time, I was concerned about capacity and explored the option with, we have one real children's hospital. We have another facility that has an inpatient children's facility, but the real major children's hospital in Orange County, there's just one of them. And I entered into discussions about potential adults going to that facility, and they were really lukewarm on that. It just wasn't something they were willing to do. And I think at the time, there wasn't as much pressure and they didn't feel the need to do that. And so I let it go. And then of course the surge subsided and there wasn't really much of an indication for it anyway, so we let it go. This time around, we're really up against it. We are looking to put people just about anywhere we can. And so it was worthwhile to re-explore this with the hospitals, and the Children's Hospital was willing to do this, but there was a substantial failure in communication, and that was on both parties. I take responsibility for part of that, and they take responsibility for part of that. And what happened was, in their serious intent to help us, they basically said they could take patients 29 years or younger, so it's not all adults, but some adults, with just a few exceptions or a few limitations, which was the conversation to me. And I failed to explore that. What does that mean? I basically just, okay, you know, it sounds pretty reasonable. And the one example that the individual gave at the time was that there wouldn't be anybody with a criminal record for pedophilia or anything like that, which made total sense. And that didn't bother me because it's not going to make that big a difference. That's what I thought we were talking about. But as it turned out, as you can see the exclusion list in front of you, it turned out to be fairly substantial. The specific thing, which was the mental health one. Many of our hospitals are just filling up with mental health patients that are acutely disturbed and can't really function. They cannot go home. They need inpatient treatment, and there's nowhere to put them. And the hospital I worked at, UCI, typically any one day we would have 4 to 8 patients in a bed for 12 to 24 hours waiting for placement in normal times, and that's only gotten worse. So the inability to take mental health patients really would compromise the effectiveness of this process going forward. Of course, cancer and dialysis is also an issue. So in the end, we weren't able to operationalize this. And in addition, there were problems where the field personnel were supposed to call the hospitals. And let me get to that slide. That's, I think, my last slide here. These were the issues that went wrong. We had asked that the field personnel, if they're going to take an adult to the children's hospital, to call, because the children's hospital is a base hospital, so they have a radio. So to call them and run the case by them before they took it there, just to make sure that there wasn't any issues. And what was happening is the medics weren't doing that because they were confused with basically the no base contact policy we have. For most cases, they're run on standing orders and they don't make base hospital contact. So a lot of these patients normally would fit into their standing order policy with no base hospital contact. So they weren't making base hospital contact. We couldn't fix that on the fly because we're trying to implement this real time and it just wasn't working. So because of all of these issues, we had to basically abandon this. And we're not at the current time going to implement this. What would I do differently in the future? First of all, I would hopefully have a partner at the Children's Hospital that remembers this time and would be willing to negotiate and work with us on how they might be able to expand their capacity. And we would try to reach an agreement on what kinds of cases that EMS sees frequently could still go there. And I think that would be the key. But it has to be done not in the height of an emergency like this one. It's simply too difficult to implement. And that's really, I think, all I have. Yep, that's it. So I'm going to unshare my screen. Oh, already did.
All you have
You guys are
is a
fast.
lot of really important information. Thank you so much, Carl. Echo team, if you could get ready to load the polling questions. We're going to go through just the first 3 polling questions. The others were repetitive from previous sessions, and we can come back to those again in the future. A question that came up, and I'll turn it to Carl, Jim, and all of the panelists. Is there any law or mandate that requires monitoring diversion and potentially prevents hospitals from going on diversion? Anything that you all are aware of?
So John, what we did in our area, no, there's no law or regulation, but we made it part of the regional standing orders. So they are required to abide by it. It is essentially a physician order to EMS to
Thank
cover
you.
the diversion policy.
Carol?
In our local system, and it goes every day, the hospital needs to justify why they're going on diversion, particularly if it's in a different hospital network, and also demonstrate what they are doing to fill the gap that caused them to go on diversion. Because there's so many things. There's staffing, it could be not discharging patients, et cetera. But they need to justify the reason for diversion and show that they're taking action on it. Which I noticed in some of Carl's slides, you had comments as to why there were 2 systems that have those comments.
Yeah, we actually have all of those things in place. We do monitor routinely. Everybody has to submit data, and anytime you go on diversion, there's specific lists of things that qualify for going on diversion. All of those comments are absolutely accurate.
Dan, did you have a comment?
Yeah, I was just going to say to tag on, yeah, diversion is strictly a courtesy provided by EMS. There's no legal basis for it. And I think that actually goes all the way back to Hill-Burton. If anybody remembers the Hill-Burton Act, that hospitals had to accept patients, et cetera. So, No one has ever asked the Office of the Inspector General for an advisory opinion on this, and I think that they're really worried. But I think medical directors need to ask that hard question and kind of step up and see what kind of answer they get. But there's no legal basis for diversion.
Carol?
One big thing, I think hospital administrators in particular need to really be educated and reminded that EMTALA, whether it's during a pandemic or not, once the patient is on hospital property, they are the responsibility of the hospital, not EMS. So if that patient deteriorates while they're waiting on a stretcher for 2 hours, the hospital has responsibility.
That's correct, which also addresses one of the follow-up questions that was just, if hospitals are going on diversion, are they closing the ED from walk-in patients? Can't do it. That's without question is illegal. We'll circle back to that and bring in more panelists in a minute. Could we pull up the polling questions? And as I mentioned, we're just going to do 3 of these. The first one you have seen before. Again, we're using it to help trend activities that are going on. But in your EMS agency today, which of the following PPE supplies are you most short of? And please indicate just the one that you are most short of. For Jim and Carl and the panelists reminder, we're not able to respond to these polling questions. So please indicate. We'll let it go just for another few seconds here. All right, Amanda, can you show us the responses, please? Not short of any PPE, N95s still lead the way for those that are short. All right, next question, please. And the next 2 are particularly germane to our discussion today. As of today, my EMS agency has experienced prolonged times at local emergency departments. Either yes, no, or not applicable. All right, let's see what we've got. Today is going to be answer questions quickly, or you. So not quite 50% are experiencing diversions. Next question, please. Or I'm sorry, experience prolonged off times. Next question, please. When you are experiencing prolonged off times at local emergency departments, what is the longest time that you have experienced? We're asking that question because candidly, there are areas of the country, widely dispersed areas of the country, where there has been significant load, where ambulance crews have experienced up to 8 to 10 hours of prolonged off time. We'll give you a second here. And the survey says not applicable in large. There are a few situations where folks have experienced greater than 5 hours. All right. Thank you all very much. I'd like to turn now to the panel for other questions, comments, or observations. And if you do have one, please raise your hand, quickly introduce yourself, and then we'll go into the topic. Anybody? Dan.
Hi, Dan Gerard. I'm the president-elect of the International Association of EMS Chiefs. A great presentation by both docs today. My question for them is, what clinical pathways have you developed for managing patients that don't necessarily need emergency department care, that they can go to either alternative treatment sites or they can be treated at home, that you've identified during COVID that you think that you're going to keep in the future and implement in your system long term? Thank you.
Jim?
I'll start and say, first of all, we developed the COVID pathway, which heavily looks at the total symptom package of the patient and pulse oximetry as an indicator of need for hospital evaluation. That one we will likely keep. We have developed a number of ET3 related protocols in the markets where that will be coming in January the 1st, and looked at candidates for care outside of the emergency department. And those obviously will be long after COVID. Third, as Carl's mentioned and as others have mentioned, the mental health burden has a potential to get much worse. I think in many communities, we need to look at alternate care sites for mental health patients and sobering centers, and use those very appropriately for the management of those patients, as opposed to EMS, law enforcement, and emergency departments. So those would be the three areas, Dan, where we've been working.
Thanks, Jim. Carl, any comments on that one?
There aren't any, so yeah, are we putting stuff in place? We are drafting policies now that would allow, basically, like I said, assess and refers. It's somewhat problematic for us because a huge section of our population does not have health insurance. So if they don't get seen by someone in the emergency department, they may not get seen at all. So there are some issues with this, but for the immediate time, we are looking at COVID-related assessments that would allow people to remain at home and not be transported. But we probably would not continue that after the current pandemic is over.
Thanks, Carl. Carol?
I'm Carol Cunningham, the State Medical Director for the Ohio Department of Public Safety Division EMS. As you're creating these plans, there may be patients who need medical care, but potentially would go to an alternative care site like an urgent care. Do you have something in your plan, or are you planning an alternate transport to get them there if the patient doesn't have transportation, such as an Uber or a ambulance, something lower than an ALS or a BLS squad that could be used for somebody who actually needs to go to the hospital?
Carol, I'm not aware of any programs in the areas where I operate. So those are the Midwest, East Coast. Our use of urgent care centers and freestanding EDs is often based on what their capabilities are, and the want for us not to have to do double transports by taking them to one place and then they have to transfer them out after some evaluation is done. I think in the long run, our unscheduled care responsibilities will include matching people with the right transport resource, not including ambulances. But as yet, in the metro areas where I've worked, that's not been a viable solution.
I would have to agree with Dr. Augustine that the use of Uber and those kind of things for us are somewhat problematic in the sense that we don't have any control over whether they'll even take the patient or not. And I can only relate a personal experience I had once with my father when he wanted to go to the hospital, didn't want to call an ambulance. He called Uber and they told him to call 911. And that's the kind of thing you just can't have happen. If we're going to create this system of alternative transportation, then it has to be functional. So we probably, if we're going to do that, would have to somehow incorporate it into the ambulance companies or some other provider we would reach out to with a contract that we would know if they were accessed would show up and do the transport. Having said that, I think that that's not an unreasonable option, depending on the funding and your patient density. I mean, if you live in a rural area, that may not be viable, but we are in a pretty urban area and that might work for us.
Yeah, I think ambulances are a good option. Again, it would have to be arranged and paid for, and they'd have to have a priority with some of their pre-scheduled runs. Thank you.
Thanks, Carol. Carl, with the mobile field hospitals that are being set up in conjunction with some of the healthcare systems, will EMS be allowed to transport to those facilities, or will they be required to go primarily to already established emergency departments?
These facilities are actually established on hospital grounds. So I'll pick an example. For instance, UCI has agreed to accept a 50-bed tent hospital, mobile field hospital, and they're putting it right in front of their main hospital. And so ambulances will still go to the ED, but this mobile field hospital will be used to offload the burden. So they may move some of their non-COVID patients into this field hospital, or they may actually use it for COVID patients that are stable, don't require intensive care, but are sick enough to be in the hospital. It's really left up to the hospitals how to manage it. We're just trying to provide the resource, but these are actually on hospital grounds and wouldn't be the receiving center for ambulances. They're still going to go to the emergency departments.
Got it. Thank you. Any other questions or comments from panelists? Garth, I can't see you, so if you've got anything, feel free to just chime in.
Well, you would happen to call on me. I'm at I'm getting my car repaired, so there's Christmas music in the background. But the Orange County presentation from Dr. Schultz sounds very familiar to what's going on in the Maricopa County area. The county's divided up into 4 sectors, each with their rotational scheme, and each and every one of them is falling apart to a certain extent. And in 2 hours, we're going to have a meeting to discuss our options, and I'll really take some of the recommendations from Drs. Augustine and Schultz to that group. But yeah, it's a problem all over, and I think that we're headed eventually to a no diversion scheme for the Maricopa County area.
Thank you very much. All right. Jim and Carl, thank you so much. I'll turn it back over to you for any final thoughts you may have. Jim?
We've got to get through this bolus of patients and then got to get and lead the community in getting vaccines. It is our way out of this, but very many lessons learned during COVID, and our challenges of moving patients through the system adequately and using other offsite services will be a positive side of where we are post-COVID. Thank you.
Thank you. Carl?
Yeah, I guess my biggest take-home point from this is doing this on the fly as the situation evolves is inherently risky with unknown outcomes and not enough time to think through the consequences of your decisions. Had I to do this over again, I probably would have pushed even harder to try and do more pre-event planning so that we would be able to roll out ideas in a more organized fashion rather than simply as in a reactive fashion.
I think that is a sentiment that is felt by many, many folks all over the place. Jim, Carl, thank you so much. We really appreciate your time and your wisdom. Panelists, thank you. Echo, again, flawless logistics, thank you. And audience, great comments and questions. I'm recording them all, and we will work to try and address them with future sessions. Again, by way of reminder, this week we are having sessions on Tuesday and Wednesday. No sessions next week, and we will be back with you all in 2021 on January 4th. Rick, any final comments?
Yeah, final comment. I guess a haunting question. When Carl said that he was their system was at the breaking point, what is that? What's going to break first? Breaking point. We've talked about breaking points for a long time, but you're at it. And so what's going to break?
The ability of an ambulance to get a patient into the hospital at all, and the need for the emergency departments to start engaging in rationing decision making and real time triage. That's where we're headed.
Yeah, thanks, Carl. And then just the other thought, like tomorrow, I was listening carefully to your presentation about the pediatric piece, and tomorrow's rounds will be on actually 2 different centers on pediatric ICU care of adult patients. So I didn't plan an advertisement, but it seems pertinent. Over.
Appropriate. Yep. Thanks very much, Rick. All right, everybody. I hope you have a wonderful rest of the day and are able to get a little bit of downtime over the holiday season and relax a little, enjoy the time with your families. Thank you, everybody. We will see you on this session next year.